Yeah, what do you know? Are you like 6 weeks or almost 2 months out of the injury? Your meniscus tear?
Um, We are about 2 months. Yeah, 2 months since it happened, and this week I did 225 on front squat, 4 sets of 5. So that was good getting back up there. I think I can do like 40, 50 pounds of like 3 sets of 12 for like single leg knee extensions. The quad strength is starting to come back a little bit. And there's still some stuff like I was doing pistol squats the other day, and I tried it on my left. I literally fell down. I went down to the bottom, and my knee it's a sharp ass pain. I just
Yeah.
sat on the ground. I'm like, yep, can't do this yet. But
Yeah,
anyway,
it's coming. I mean, that's
it's
you're
coming around.
already doing really well without surgery. It's just now the next
Yeah,
test is going to be how do you do when you get back in sports?
right. Yeah, sports and long term, right? How's it gonna feel 2 years from now, or even 6 months from now? But yeah. So, anyways, we got a good one today. I think we'll have a lot to talk about. We are going to be discussing a different podcast from, is it the Tim Ferriss Show or the Tim
Tim
Ferriss
Ferriss Show.
podcast? Yeah, Tim Ferriss Show. Yeah. He's a very well-known name in the podcast industry, I would say. He has like 16 million followers on YouTube or something like that. Like more than us. So, but he had Dr. Keith Baar on, and Dr. Keith Baar is a physiologist. He has his PhD in physiology at, was it UC Davis? Yeah, UC Davis. And the title of this podcast that we're going to be talking about, if anyone wants to go listen, is pretty heavy in terms of technical terminology and like kind of getting the weeds on some stuff. So we'll try and break that down to make it a little more easy to understand. But it's called New Strategies for Exercise and Recovery. And so they're going to discuss a lot about tendon and ligament rehab or preventing tendon and ligament injury. And there's some other stuff in there as well that kind of goes with it. But for the most part, one of the big things they touch on is isometrics and utilizing isometrics in preventing and rehabbing from these types of injuries. So we'll be talking a lot about that today.
Yeah, absolutely. It's overall I thought it was a great podcast. It was incredibly insightful. I listened to it twice in preparation for this, and I read I think two research articles from Dr. Barr, especially his 2017 one that pretty much served as the outline for the entire podcast. All the same arguments in the podcast were made in this article from 2017. And overall, I think it was awesome. It was cool to hear his perspective as a physiologist, molecular and cellular biology guy, and all the different mechanistic studies that he talks about, and then just trying to relate that to modern physical therapy and medicine and how we practice with a real person in the real world. And we're going to get into that too about how much can we translate Dr. Barr's information from the research lab into real life.
Yeah, and I think that's a good point to bring up too. Is a lot of the studies that they talk about, or I guess all the studies that they talk about in the podcast. I mean, a couple of them are like case studies, almost case reports. Which that's for people who don't know, case reports is kind of like the lowest, I don't know, credibility level of like research studies, right? Because it's an N of one and or very low number of subjects in there, and just everyone's different. And so when you do a case report, you might do something with an individual and it looks really, really good, but it's like that's just one person, right? You have to extrapolate that into the larger clinical trials. So they have case report studies and then also like in vitro studies. And so, like, what that means is they would kind of like synthesize like tendons or ligaments, this tissue within the lab, or they would extract it from like a rabbit or a mice, and then they would go from there and they would do these different like loading on those tissues, and then they would dissect that and look at it under a microscope and see a bunch of cool stuff. So a lot of the things we talk about today is going to be based on that, which it all sounds great, but there's not a whole lot of like large clinical trials, systematic reviews, meta-analyses on this. So in terms of this stuff being in our clinical practice guidelines or things we would really fall back to, it's not quite there yet, but it's a lot of really good information that I think is still going to be applicable to what we could do with our patients.
Yeah, I guess we'll just stay on that in vitro versus in vivo to lay some groundwork here. So, like you said, in vitro studies, that's petri dish stuff, that's research lab. That's the best way for us to figure out how and why things work from just like a science perspective. But then you have to take those exact thoughts that you have and put those into real people. That's called in vivo. And when it comes to being a practicing physical therapist or physician, really we only care about what's happening in vivo, what happens in the real world with the real person in front of us. And when you take the petri dish stuff to real people, there's a lot of extra things that happen, and you can't quite draw a perfect correlation between the two. Because when you're doing work in a petri dish, you've got tendon or collagen fibers just growing in this really controlled environment. But in a person, you have all sorts of confounding things that can mess with the quality of the work that you're doing, such as a blood vessel interaction. You have systemic or local inflammation from whatever other conditions this person might have. You have their ability to remain consistent with a plan. We all know that we're not all going to do the exact same workout the same way because of our motivation, our stress, our barriers in terms of physical issues or time, whatever it might be. And then the big elephant in the room is going to be pain. When someone is in pain, you're trying to help them as a physical therapist. I might have this really cool protocol that I want to give you, but it's not going to work for you because it's too painful and you're not going to do it. You can't handle it, and you're just not going to hear what I have to say because it's just not going to work for you right now. And so as physical therapists, we're more concerned with what works in the real world in those in vivo studies and how we can get you to do a thing, and then what things that we recommend for you are the most palatable.
Right. Yeah, and also just to stay on that idea of pain as well. As PTs, we've mentioned this before, but we practice in the realm of the biopsychosocial. And so it's not just the biology, which this podcast we listen to is very heavy on the biology of everything. But pain is also influenced by psychological and social factors as well. We know that. And so we can have the best protocols, do everything by the book, and individuals still might have trouble with getting rid of their pain because pain is a lot more than just the biological. But with that being said, again, we still think this podcast offers a lot of really good information.
Yeah, so let's go right into what Dr. Baar's major claim is. From my understanding of what he said, his major claim is that isometric exercises, where you're holding against a resistance for time without moving, are really essential to helping people with tendon or ligament issues, and they're underused and poorly understood by really all people, but especially medical practitioners. And when it comes to physical therapy in particular, the big thing that we do for treatment for these issues is going to be eccentric training, so lowering a weight against gravity and trying to slow that thing down. Dr. Baar's argument is that isometrics are generally better than eccentrics at helping people with these tendon or ligament issues. And I think that's the bulk of his summary. But what do you think, Eric?
Yeah, no, I would agree. I think that's pretty much good. I think a good synopsis of what he was talking about. And to go off of that, the reason why he makes a claim that the reason why eccentrics work or were shown to work with individuals with like tendinopathy is because of two things. One, you're loading it heavier, and two, you're doing it at a slower rate. And so it's almost more like an isometric than concentric, right? But it's technically an eccentric, but it has some properties of an isometric because you're doing it at a slower rate. You're almost getting to a point where you're not having a whole lot of change in the length of that muscle at certain points of the movement. And so that's why his claim was like, that's why eccentrics seem to be working, is because you're loading it heavier and you're moving slower. And so I think this is probably a good point to get into a couple of more technical terms, which one of them is called stress shielding. All right, so what he discusses with stress shielding, and this is going to come up later on when we talk about like boots or braces around certain joints. But stress shielding is when, so you have a tendon, and the thing with the tendon is that not all tendons are created equally. And what we mean by that is it's a heterogeneous structure, which means the tendon isn't just one. Like if you take a part of the tendon near the bone and you take a part of the tendon more in the middle, that it's not all the same strength, right? There's going to be weak points in there. And so because of that, what stress shielding is when the stronger parts of the tendon are going to take the load and it bypasses the weaker parts, right? And if you just do concentric contractions, or, maybe if you're doing eccentric contractions, but it's not heavy enough or it's not slow enough, whatever it is, and then the stronger parts of the tendon just keep taking over. And the weaker parts of the tendon, the parts of the tendon that could be theorized that could be causing the pain, those are not being loaded. Those are not being, strengthened. And so the reason why isometrics that he proposes is so much more beneficial is that as you hold that contraction over 20, 30 seconds, whatever it might be, 15 seconds, we can talk about protocols here in a little bit, but as you hold that contraction, the stronger parts of the tendon start to fatigue out, and it's forcing the weaker parts of the tendon to have to start taking on some of that load. And then that's going to cause that adaptation to improve said tendinopathy.
Yeah, and he gave a really good metaphor for this, which was his tug of war example, where he, let's say an average build, average height person was on the same team as The Rock, who's absolutely jacked, and they're doing the tug of war match. Mm-hmm. And initially, at the start, The Rock is going to carry all the load. That's the stronger bits of the tendon in this metaphor. But if you go long enough with this tug of war, The Rock's going to get tired out, and then Dr. Baar, the smaller dude, will have to start to pick up some of that slack. And that's where you get through that stress shielding, where the stronger bits get tired. Now the weaker bits get a chance to do the work. And Dr. Baar's whole argument is that isometrics are critical to getting the weaker bits to be exposed to some stress so they can then adapt, because the rule in any tissue, muscle, tendon, ligament, is that you have to add stress meaning force of some kind, to the tissue at the right amount, and that is the signal that makes the tissues grow and get stronger. And if you don't do that, it just doesn't happen. And the classic metaphor that we have in physical therapy that's been around forever has been the donut in the hole. And so you imagine a damaged tendon is like a donut with a hole. Traditionally, we focus on strengthening the healthy donut part around the hole, as the damaged area was thought unable to heal very much. So we focused all of our efforts on training the remaining fibers, the strong fibers, and just kind of neglected the weaker bits. And that was mainly because a lot of our studies showed that the weaker bits just didn't really have the capacity to heal that much. All the stuff we were doing to them wasn't working out that well, and it seemed like it was a fool's errand to keep chasing that adaptation. But people like Dr. Baar for years have been pushing a different narrative, which I think is totally useful and valid, in that maybe we're just not strengthening or applying the right stress to the whole, and isometrics are the key to making that happen. And so we have to hold the isometrics with the right amount of weight over the right amount of time to eventually make those weaker tissues or the whole to get that stress, like we said earlier. And this is where I was thinking a lot about this podcast in the first playthrough and the second playthrough around what we're doing in physical therapy for folks with mainly prescribing eccentrics or concentric eccentrics and not using isometrics as much. I'm sure we're going to share a bunch of thoughts on that.
Yeah. I think it'd be good to get into more of the protocol stuff here. And so one of the things that I found really interesting in the podcast was that Dr. Baar discusses what's called a refractory period. And that's basically a period of time where you're going to get minimal return on what you're doing, right? So like, for example, this is what he discusses for kind of his protocol, was doing an isometric, 10 to 15 seconds on, and then giving it is it like a 1 to 2 minute rest break? I might have misremembered that.
10 seconds on, 50 seconds off.
50 seconds off. That's what it is. Sorry. Yep. And then you're going through that for, what do you say, like 10 minutes? Yeah. Okay. 10 minutes. And so over the course of that time, you're fatiguing out the tendon as you're doing these isometrics from the idea of the stress shielding. Well, once you get past that point, you fatigued it out so much that if you keep doing any more, the amount of progress you're going to make is so incremental that it's not going to really add up to a whole lot. And so the point that he makes is that there's a refractory period, which means kind of like a rest break. You need to utilize this really long rest break so that the tendon as a whole can come back and do the training session again, and you start back at 0, build up, and then you have to let the refractory period do its thing so that it can come back down and keep building up like that. And so the refractory period for tendons, he says, is about 6 to 8 hours. And so if you do this twice a day, ideally you do it in the morning, wait, give or take 8 hours, and then you do it at the end of the day. That way you can get 2 training sessions in and optimize the ability for that tendon to respond and adapt to the isometric training.
Yeah, he also had a pretty good metaphor for this where he said it's like talking to my 17-year-old daughter where she might listen to me for 5 or 10 minutes, but then after that, if I keep talking, she's done. It's just like she's not listening at all. That's the refractory period where you only have 5 or 10 minutes of useful work, and then after that, it's over. And you need 6 to 8 hours for your daughter to come around again and be able to listen to you. So that is something we all know that to be true in strength and conditioning. It's not a black and white thing. We don't know exactly what time it is, how long it is for each person, how much it matters for each person. But that's something we're always trying to figure out because that helps us better understand how much exercise do we give you? Do we give you a every other day plan? Do we give you an everyday plan? Do we give you a 2 times a week plan? Like, what do we do? How much work can you do and how much benefit can you get from that work before we hit diminishing returns where you're just kind of wasting your time and all the benefit that you got from the exercise was done in the first 10 minutes, but now that extra 30 minutes you did afterwards was useless. That's a big unknown. His claim comes from in vitro studies where he just had some tissue in a petri dish or some other kind of experiment, and they just tested it over and over again, and they tried to get a sense of how much adaptation occurred in what time, and they just plotted that out in a graph, and they figured that the 80% of the benefit you're going to get happens in those first 10 minutes, and then after that it's not much. It takes a lot longer to get that remaining 20%. It's not really worth it. But, how much does that transfer into a human being? That's where we don't know. I think it's certainly worth doing, like using the idea of the refractory period with a patient if they're okay with doing a 2 or 3 time per day plan where morning, noon, and night you are doing 10 minutes of tendon or ligament-based exercise. Practically speaking, not everyone is going to want to do that. They're going to be like, I'm going to do these exercises maybe in the morning, maybe at night, depending on what my kids need or what my work requires. And then I'm also not really feeling it this day, so I'm going to skip today. I don't really want to do it tomorrow either. It's just like that. That's the reality of working with people.
Yeah.
So we got to figure out what's the right dose or the right amount to give people that aren't going to follow Dr. Baar's clear protocol. And for me, like, in my experience, people do not want to do stuff 3 times a day. They don't want to do stuff twice a day. They don't want to do stuff every day. They don't. They literally do not. In our exercise plans, we plan for that. I might say, I want you to do these exercises every day, knowing full well they're going to come back to me in a week or 2 and be like, yeah, I did them like 3 days a week. Perfect.
Yeah.
That still works for me. That's good enough.
Exactly, yeah. More than what would have done regardless. And I think for me, like, the people that will do it 2 to 3 times a day are usually the people that are post-op because they're set, they know, like, they're in that mindset of, like, this is what I gotta do versus someone who comes in not post-operatively. Like you said, they got life going on. They got different stuff going on. They might not be super motivated, like they want to get this thing better, but it's not the end of the world if they have to miss a day or something. So yeah, no, I totally agree with what you're saying there in terms of individuals and kind of how practical life stuff can get in the way. So, okay, let's move on. There's 2 different types of isometrics that they discuss in this. And I want to kind of break these down because the way, maybe you can shine some light into what I was, when I was listening to this and how my thoughts were going, Christian. But they discuss what's called yielding isometrics and overcoming isometrics. And the way that he made yielding isometrics sound is that it's just an eccentric movement. Like, when he's discussing yielding isometrics, that was when Tim Ferriss was explaining to him what he was doing with his cast iron pan to try and improve his, tennis elbow. Well, he was, for people that aren't watching the video, I'll try and explain it. He was holding the cast iron pan in a neutral grip, which means his thumb was up, And then he was slowly lowering the pan down by doing what's called pronation. I think in the podcast they said it was internal rotation of the forearm. That's technically pronation, where you slowly lower the pan down by going palm down and then bring the pan back up to neutral and so forth. And so that's what he described as yielding isometrics. And I don't know, to me, I'm like, that's just eccentrics. Like, I don't know, I don't get the difference between yielding isometrics and eccentrics. Anyways, and then he also discusses overcoming isometrics, which to me, that just sounds like isometrics. And so when he discusses overcoming isometrics, that would be like if you were sitting in a knee extension machine and you were going to try and, kick your foot up or push the bar up on your shins so that your knees went straight. What you would do is you'd put a weight on that you couldn't necessarily lift. You'd have to try really hard to lift it. So what you do is you get your legs up to the pad and you start to progressively put force into that without moving the weight stack. And as you put force into that, you should feel a good amount of tension in those quads and the patellar tendon. And that's where you hold for 10 seconds and then relax. Isometrics versus overcoming isometrics. I felt like yielding isometrics is just eccentrics, and then overcoming isometrics seems like just regular isometrics. But anyways, what are your thoughts on that? Because maybe my perspective might be off here. I don't know.
I don't recall exactly what they said, but there are two distinct types of isometrics. So there's a couple names. There's yielding versus overcoming, or it's often called PIMA or HIMA. So pushing isometric muscle actions and holding isometric muscle actions. So holding is the same thing as yielding, and pushing is the same thing as overcoming. And I'm going to get into this for a second. So I'm going to stick with the names yielding and overcoming. Those make a lot more sense to me.
Yep.
Yielding is pretty much what you said, Eric, in that you can lower that pan into the position that you're looking for with an eccentric contraction, or you can just place it there. But then you're going to hold it. So you're holding that weight against gravity. That's an isometric contraction, but there's a force of the pan with the gravity pulling you down. Okay, you're trying to fight that. And that's like a wall sit. So you're using your quads in the wall sit, and you are trying to fight gravity pulling your body weight down. Now, in contrast, overcoming is really just you exerting force into an immovable object. So an example of that would be doing a quad extension up against a wall. So you're trying to kick your foot into a wall at whatever strength you're looking for, but that wall is not going to move no matter what you do. So the difference is that yielding and overcoming isometrics recruit the muscle and tendon fibers and your nervous system in slightly different ways. They both seem to yield a lot of really good benefit, but Dr. Baar is arguing more for the overcoming isometrics. And I think in other stuff that I've read, other podcasts I've listened to, namely on E3 Rehab, because they interview researchers that talk about these things regularly. Really, you're going to choose the type based on the client's response and what they can do, where overcoming isometrics are usually less stressful. They usually feel a lot better for the client, and they get a lot of really good benefit. So those are the ones that I tend to prescribe for people early on, the overcoming ones, so kicking your foot into a wall, especially after knee surgery. If I want to get you doing a quad extension, that's a really good way for me to do it, because you can scale the force as tolerated. I don't need to worry about setting up bands or putting on ankle weights. I'm still going to get a lot of really good benefit, and you're in total control. I'll do the yielding ones where you're resisting the force from pulling you down as you get more comfortable, as you get stronger, and as I want to really add external load and maybe even start to play around with some of that eccentric loading.
Gotcha. So the yielding isometric seem to be more of you're holding the isometric at the sticking point, basically. So if you're a bottom of the squat, you'd get down, hold that, and then come back up. Okay.
That's right.
Yep, that makes sense. Okay. All right, awesome. So the other thing that I thought was really interesting that they discussed was this idea of jerk. And so what jerk is it is the change in the acceleration of the tendon. So when you accelerate, and I guess when I thought about this, I was thinking of it obviously in a car. So if you're going forward in the car, and as you're driving forward, let's say you come to a nice slow stop and then you shift it in reverse and then you go backwards. So that's changing the acceleration from a forward acceleration to a backwards acceleration, or like a positive to a negative. Well, it's the same thing within the tendon. And so as you're lengthening that tendon, you're accelerating in one direction. And then let's say you contract it and then it shortens and then you accelerate it in another direction. And their discussion around this is that jerk can be kind of seemed like jerk is the reason or a reason why we can get something like tendinopathies in the first place, is because we have these high amounts of jerk or quick changes in acceleration. And there's a really good example I want to discuss once we kind of talk through this here, Christian, but it's that change in acceleration within the tendon that can make the tendon damage or make something like a tendinopathy occur because of that quick change in acceleration. And likely repetitive as well, not just one time, but over the course of many, I guess, jerks.
Yeah, I thought that was a really cool way to explain it. I actually had not heard that term. I don't know if
I haven't either.
Not knowing that term.
No, I'm with you. I'm in that camp too. I didn't hear it either.
But that it brings up a really big topic in our field and in just like everyone's typical conversations day to day. Like, oh my God, that person's at the peak of their game. I think you're going to bring up an example with an Achilles tear, probably.
Yeah.
Yeah. Cool. So we'll get to that next, but it's like this person's seemingly healthy. They're at the top of their game. They're a fantastic athlete, and they're like in their 20s or their 30s, and all of a sudden they tore their Achilles. You're like, oh, how the hell did they tear their Achilles? They looked so good. They didn't have any pain at all. Nothing. They seem strong. Because all these athletes are doing exercises. Of course they are. And it's not like there's some glaring, oh, they can't do a calf raise on their right side, and that must be the problem. We have no idea it's a problem until it is.
Mm-hmm.
And so the idea of jerk was really cool in that it's that rate of change of the acceleration that seems to, especially when you're fatigued, go right through those strong bits of your tendon, that stress shielding thing Eric talked about before. And when those are tired out, all that stress from the jerk goes right into those weaker bits of your tendon, and the tendon just cannot handle it. It cannot handle that amount of force, and that's when it goes. But you never really knew that was a thing because you'd never trained your body into that level of fatigue. And so those weaker bits were always shielded from that force. But when the moment came when they were no longer able to be shielded, things happened. But yeah, so let's talk about your example, Eric.
Yeah. So the example that came to my mind that's very recent for those of you who follow the NBA and basketball. I was thinking that you might have heard of this one, Christian, because it's a Boston athlete that happened to.
I talked about it last week.
Yep. Oh, yeah. Yep. Yeah. So for those of you who don't know, last week the Boston Celtics were playing the New York Knicks, and it was a very close game coming down the stretch. And I want to say it was like 2 or 3 minutes left in the game. Like it was at the end of the game. And so clearly a lot of players, probably all of them, fatiguing out, right? And so Jason Tatum, who is, I think he's in his later 20s, probably like 27, 28, something like that. He's a top 5 player in the NBA, right? So he takes, I can imagine what he does to take care of his body, right? He probably has all the resources, does all the right things, has a lot of high-level minds around him that are programming stuff for him. And he was going to kind of come around the top of the key, and he started from a standing position. He took a step back with his right leg to kind of push off, kind of like a sprinter would out of the block, kind of. So he steps back with the right leg. He loads his Achilles into what would be a dorsiflex position. So steps back, and that dorsiflexion angle comes closer. And then as he pushes off to go get the ball, as he pushes off, he immediately goes down, grabs his Achilles, or grabs his ankle, and is in clearly a lot of pain, distress, because he probably knew internally something terrible just happened. And so what happened there, and it was later confirmed the next day with MRI that he tore his Achilles, and then I think they said he got surgery like the next day too. So like that's nice to be able to just go right into it.
Wow, damn.
Right. So what happened there? So probably at the beginning of the game, through the first 3.5 quarters, his stronger parts of that tendon was able to take a lot of the load that he was putting on it throughout that game. Well, as it went on and those stronger parts fatigued and he no longer was able to stress shield the lower parts or the weaker parts, he put a very stressful force. He went from a lengthened Achilles tendon very quickly into a shortened or contracted Achilles tendon. And he did that with all of his body weight, right? So he probably weighs like, I would guess like 220, 225. Just throw that number out there. So a very quick rate of change in acceleration from a lengthened position to a contracted position. And when you put 200 plus pounds into that, something bad can happen. And the stronger parts were fatigued, and then the weaker parts tried to hold on for dear life. They couldn't, and bam, you have an Achilles tendon rupture.
Yeah, I think that's a really good way to break down what Dr. Baar is talking about. Because that brings in the idea of jerk. It brings in the idea of maximal tension, like when you're in that really like foot backwards, massive dorsiflexion range of motion. So your calf is on a lot of stretch. Your Achilles is fully stretched out. Then you add all that jerk force. Yeah, I mean, that given what Dr. Baar is saying, that's a recipe for a problem. And the one thing I'll add about Achilles tendons is this isn't black and white, but it seems like the people that tear almost never have warning signs. They don't have pain. People that have pain in their Achilles tendon, that's their body saying this is a problem, and you're less likely to tear if you have pain than if you didn't. And
Yeah.
I don't know if that athlete had pain or not, but that's just something that we seem to see in physical therapy, where it freaking comes out of nowhere. It's the worst thing. You were not expecting it, and totally ends your season. Even if you get surgery the next day, it's done for a whole year.
Yeah. And I mean, even too, like, look at it in like baseball players. You can see baseball players, pitchers. There's videos of it. You can find it. I watched a video like last week or 2 weeks ago. It was just it was like 2 minutes, and it was pitcher after pitcher. And they would just be warming up in the fifth inning, getting ready to go. And they would throw a pitch that they've thrown hundreds of times that day. And they throw it, and you can see them immediately grab their elbow or their shoulder, whatever it is. And again, they probably felt just fine. Didn't have pain. They threw it, and that ulnar collateral ligament goes, and now they have to have Tommy John surgery, right? So we can see this in other parts of the body in other sports as well. It's not just the Achilles tendon, but for some reason in the last couple of years, it just seems like the Achilles tendon has been more prominent for some reason.
Yeah, I mean, that's a whole separate podcast where, like, are we reaching the limits of human potential? I don't know, probably not. Or do we need to get smarter about our training? Because a big risk factor for all these injuries is going to be excessive specificity. So doing too much of the same stuff and not enough variety. And, you know, you look at any professional athlete, even youth athletes now who just at 8 years old, they're playing in like 3 different soccer leagues year round.
Yeah.
Thing up here by us.
No, yeah.
That's the kind of stuff that we know for a fact is leading to more injury. And I think that's something that's cultural and something we should probably be working on to reduce these issues.
Yeah.
But at the very least, adding in more variety of training so that you're not getting excessively specific. But I think that example brings us to one of Dr. Baar's ideas on RICE, or rest, ice, compression, and elevation. And immobilization, or using a boot after an ankle sprain, or putting on a brace in the knee after an injury. And I know you had some thoughts. I think it'd be better if you start with yours, and I'll more so react to your thoughts.
Okay. All right. That sounds good. So one of the things I wanted to hone in on was this idea of like a boot, or I think you could even extrapolate it out and say like an ankle brace as well. And so the idea of this is what is the purpose of a boot, or like a cam boot, or, you know, like a ankle brace of some sort. And really what it is it's an external device to stress shield, right? So it helps take stress and it protects that area that might be under fire. If it's your anterior talofibular ligament, or if it's a, you know, Achilles tendinopathy or post-op Achilles rupture, whatever it is, we utilize things like boots and ankle braces to stress shield them so that they can recover. Well, one of the things that Dr. Baar brings up is that if we're stress shielding them, and then we're actually promoting the tissue, the ligaments and the tendons to not work as hard. And when that's the case, there's a study that I think Tim Ferriss brought up of this gentleman from Japan who put a metal rod inside of I think a rabbit's like knee. And they found out that after 2 weeks, this rod took off all the pressure of the patellar tendon. And so the patellar tendon wasn't being loaded. Although it was intact and quote healthy, the patellar tendon showed all the signs of scarring, right? So the idea is that if we're stress shielding a lot with these external devices, and then we might actually be promoting something like scarring of the tissue because it's not being loaded, right? Couple of things with that. I think one, if you look at our CPGs for like lateral ankle sprain, there's actually not great evidence that we don't really suggest for like secondary prevention of like an ankle sprain. There's not great evidence to be wearing ankle braces versus like they can be used like while in competition as like a primary preventative, right? To try and prevent it in the first place. Like there's some research behind that. But so one, I want to make the point that I would say in physical therapy, we've already been saying this, or we've already been doing this in terms of not overprotecting things, at least in the physical therapy realm. Now, I think his point that he brings up is like if you go and see a family medicine doctor or someone who might not be as well adversed in this, you know, they're going to prescribe like a boot or an ankle brace when in reality, maybe it's just a low grade sprain or a strain, and we shouldn't be protecting it. We should be loading it and doing these different things he talks about, like the isometrics, etc. But one of the things he brings up in the podcast, I thought this was just kind of funny. He asked Tim Ferriss, or they talk about when was the idea of like wearing a boot first recorded in human history. And he goes on to say that the first recorded idea of doing this was from ancient Egyptian hieroglyphs, and which are like 4,500 years old. One, I would question the communication or the language barrier of how we're interpreting said hieroglyphs if they're prescribing cam boots 4,500 years ago. But two, he goes on to say like, he was like, could you imagine if your doctor was prescribing like a cancer treatment that was 4,500 years old? Wouldn't you think we would have better ways to treat cancer than a 4,500-year-old technique? And to that, I'll just say, you know, an ankle sprain isn't cancer, right? Like it's not a fatal diagnosis that's going to kill you. And so, yeah, I get where he's coming from with that, but I also feel like that makes things such as boots and braces, you know, give them kind of that antagonist viewpoint. It's like, oh, we shouldn't be using these because we're stress shielding and we're going to cause, you know, scarring and bad things to, you know, happen, and it's working not in the patient's favor. Well, I think it just takes more of a discussion in terms of should we or should we not be stress shielding with these different devices, because there's other things than just having a sprain or a strain, right? I mentioned before, if it was a stress fracture or a fracture of some kind, like I would hope that we're giving it some stress shielding to that bone to prevent further injury to that. Or if it's a really nasty ankle sprain or really nasty strain. And then again, I would advocate that maybe we should be adding some stress shielding to this. Or if you're looking at someone's pain level, right? Maybe they're super irritable, like 8 out of 10 pain trying to weight bear on it. It's just a really bad strain. Well, yeah, let's give it some external support so that you can actually do some stuff throughout the day. And maybe you're not loading it 100%, but if you're loading it 50%, I would argue that a week of 50% loading is going to give us more benefit than, you know, trying to power through at 100% loading, right? So I hear where he's coming from, and I get the argument that he's making when it comes to boots and braces and whatnot, and how they're these external stress shields to those tissues. But I just think that there's more dialogue to be had in terms of like what is actually injured, how severe is it, and what is the purpose behind it. Now, again, I think he was coming at it from someone who might not be well adverse in these types of issues, like a family medicine doctor. But again, I don't want people to think that boots and braces are the devil's work and we should never be prescribing them for any type of injury.
Yeah, in that part, I guess in a couple other parts of the podcast, he does come off like he's trying to market himself as this like savior in tendon and ligament rehab, and he's got all these great plans that no one's listening to him about, and he's trying to make his case. He's kind of edgy about it, and this is where I wanna give him the benefit of the doubt and say that I don't know the whole story. I don't know how long he's been doing this for. I know one of the articles I read was from 2017, which is a year after I graduated PT school. So he's been at this for a very long time, and he's probably been making the case for early weight bearing after injury and early mobilization, early range of motion work, minimizing anti-inflammatory use as much as you can, because you do want some inflammation to heal the tissue. If you squash it all, you're not going to get any better. And so he's probably been advocating for these things for a very long time, and he's still just saying the same thing, kind of like Bernie Sanders. Bernie has been on the same political message for like 100 years, and he hasn't really changed it. Maybe Dr. Baar is very similar, and he just needs to make sure that he keeps drilling the same message over and over for the people that aren't caught up with the science. So in physical therapy, Eric, you and I are very much on top of this stuff, and I think our profession overall is. But like you said, primary care doctors, they have a million things to know all at once, and they can't know everything about musculoskeletal care. And so perhaps he's more targeting his message towards those people, or the lay people who get a minor sprain and don't need to see their doctor. They just want to handle it themselves. He's saying like, just use the thing, move it. Don't be worried about it. So that's my take. But he does have that air of like a conspiracy theorist. Like, mainstream archaeology doesn't want you to know this thing about whatever. It's like, dude, okay, we know, like, we understand, but that's us coming from our place of being pretty well versed in this material. But yeah, I'll give him some grace there.
Yeah. You have a much more, I guess, benefit of the doubt perspective than I did when I listened to it. But again, I don't disagree with what his message is. I think it just takes some more. I think this is good why we're talking about this, although we're not going to probably get nearly as many people listening to our podcast as they did. But it's good to talk in terms of like specifics and talk about that gray area, because that's what rehab is. That's what human anatomy and physiology is, or at least in the rehab perspective, is there's a lot of gray area. And some of that has to be pieced out and put together. And so, right, if it's a lower grade sprain, or if it is a tendinopathy of some sort, yeah, I would agree. I don't think we should be putting on these braces and giving this external stress shield to it. But again, I think there's nuances in there, especially if there's something like pain that we're trying to mitigate and deal with as well.
Something I want to add about this that I think most people don't know is when it comes to surgical repair of your rotator cuff tendon, your Achilles tendon, and deciding when to load it, how much to load it. So there's a thing called ethics, where in research, you can't just take a bunch of people with an Achilles tear and then they repair it surgically, and then you put two groups of people into a study. One group does no weight bearing and no loading for some time, and one group does weight bearing immediately. If we're uncertain of the damage early weight bearing and loading can cause, and we harm that group who had surgery and then they retore it a week after putting weight through it, that's unethical. That is like not okay. And so what happens in surgical research is most of the time we have to base our recommendations on what seems to happen when people test the waters of their own rehab. So the surgeon's going to give you like, hey, based on our best guess of normal tissue healing times and people your age with this kind of surgery, we want you to refrain from loading for this many weeks, usually like 4 to 6 weeks in a typical tendon repair, or the loading is very, very minimal. What ends up happening is some patients come in at their post-op follow-up 2 weeks later. They're like, oh yeah, I've been just walking on this thing. It feels great. When surgeons hear enough of those, they begin to be like, maybe we are okay with loading this, because there's no ethical issue if the patient is choosing to load it more or earlier themselves, and it wasn't our recommendation. And so when it comes to deciding how much load to give a post-surgical patient, a lot of it is based on just knowledge we gain through experience over time, not some clear black and white study like Dr. Baar is able to advocate for, because his tendons that he grows in a petri dish that he damages and then repairs and stresses, those aren't in real people. There aren't lawsuits waiting to happen. It isn't a human being that a surgeon does not want to harm. They're trying to help you, not hurt you. So that's like Dr. Baar gets a little animated about that process of like I had this colleague, physical therapist from the Aspetar clinic, who talked to all these different surgeons and said, you're all doing it wrong. You got to load these tendons. It's like,
Yeah.
yeah, buddy, but like, it's not your medical malpractice on the line.
Yeah.
We can't just study this the way you say we should. And so I think everyone, professionals and patients or clients, need to understand that we're doing the best we can while not trying to harm you.
Yeah. And you forgot to add that physical therapist from the Aspetar Clinic is the best physical therapist in the world.
I know, I love that line. More of that, like, it's just more
My
of
God.
the edgelord hyperbolic comments, that's
Just
all they do. It's like, oh, yeah, that's the best research in the world that no one knows about, no one pays attention. It's like, come on.
just whatever gets the clicks, man. Whatever gets those goddamn clicks. Yeah. That's the other thing I wanted to bring up too was he mentioned like post-op Achilles. Tim Ferriss has a buddy that like literally just had his Achilles repaired, and Dr. Baar, he brings up about how, like orthopedic surgeons hate him for saying this, and that he would say, he should be doing active range of motion and like 20% loading of like isometrics, or just like very, very low isometric loading to that foot and ankle. And I think I told you this before the podcast, but I'm like, this idea of early mobilization, this idea for any surgery, not just Achilles, rotator cuff or ACL or meniscus or anything, right? Again, we mentioned this before. We've been doing this in physical therapy. I felt like in the podcast, he made orthopedic and sports med surgeons sound like they're stuck decades in the past in terms of their post-op protocols, and like they don't know what they're doing. And kind of like to your point, the whole idea of ethics and whatnot, I would argue that we've been doing a lot of this idea of like early loading, early mobilization, really to the best that we can. That's ethical, right? Because like you said, it's not their malpractice on the line when they want to talk about these different things and promote these different things. And so I also just want to touch on that. To what is appropriate for us and the patient, we do get them moving early, especially with range of motion. And if it's appropriate, especially with loading as well. So I would say that that's something that we've been doing after surgery, again, in ways that are safe for the patient.
We just had a presentation at work from two orthopedic surgeons. They do shoulder surgeries. So rotator cuff repairs is their bread and butter. And they were selected, this practice, it's Maine Medical Center, and these two surgeons, they were selected by this company that has a new surgical device out. It's basically a sewing machine in a gun form. Because usually when it comes to surgery, when they have a tendon, they stitch it back together by hand, making these loops and knots and such. But this new sewing machine gun basically does a stitch across your tendon, and it is already proving to revolutionize the game of surgery. Like only I think like 5 practices in the nation are using this gun right now, and they were selected because of their superior outcomes nationally. You wouldn't believe it, but Maine Medical Center has some of the best surgical outcomes in the entire country, top 3 or top 5. It's an incredibly good surgical practice. And what we've already seen with these new surgeries, and we're getting them in our clinic right now, is so normally when people have a standard rotator cuff repair, they are in a sling for 6 weeks. They're told to not really use their shoulder much. And that's because traditional rotator cuff surgery has a 40% 1-year failure rate. So you get that surgery, it's almost a coin toss whether it's going to stick and work for you or not. That is horrible. Those are horrible outcomes. And so we want to make sure we're careful because people do re-tear very early on if they use that shoulder before that 6-week immobilization window. That's something we've studied forever. So you have to protect it a bit. But this new surgical technique, we are seeing people come into the clinic, or they even showed us videos too, of getting full range of motion, arm all the way overhead at 2 weeks. 2 weeks surgery. They advocate, the surgeons are recommending for their clients to wear a sling for only 10 days. The surgery is that good.
Wow.
And this is the thing I want to be clear about. It's not just because the tendon itself hasn't healed that much in 10 days or even that much in 6 weeks. It takes months for the tendon to heal. It's going to remodel for up to the first 1 to 2 years. It's a very slow structure to heal. It's the surgical technique itself and putting it together in just a more mechanically stable way is what's going to change the game. Not, look, I want to believe it's going to be isometrics are going to help somewhat in that early regeneration of the tissue, but it's mainly going to be the surgical technique that the surgeons are doing. That's what's going to change the game the most.
Yeah.
And the last thing I want to say is it's not like people that have surgery are completely immobilized, not using it. When you're in a sling, you're still using your arm day to day. You're just using it less. There's still gravity pulling down a little bit, and you're getting tension on that rotator cuff repair. When you have your ankle sprain or your Achilles repair, you're still going to be walking around in the boot. They usually tell you to put toe touch weight bearing down, which means you're putting some amount of force through it. It's not like it's completely unloaded. So isometric contractions are still happening from day one. They're just maybe not done in the most dedicated fashion that Dr. Baar is advocating for. But maybe that's something we're going to be changing soon.
Yeah, and I would agree. Even if it's not post-op, if it's some type of conservative measure, like you said, people are still walking on it. People are still using it. There's still load from gravity or body weight being put through that structure. And now, is that load as beneficial as doing a dedicated isometric program? Probably not. It's probably up in the air for debate on that. I would put my money on that. It's not as beneficial, but it's still some load. So anyways, another thing I wanted to talk about that just came to my head is they were talking about this idea of pithing. Yeah. This was like more towards the end of the podcast.
Wheelhouse, Eric. I knew you were going to talk about this. You're going to love this shit.
Now we get to, yeah.
Oh my God, here we go.
I didn't come into this podcast wanting to make some hard takes, but I guess we've already done a little bit of that, and now we're probably going to get more into it. The idea with pithing, or he also said it's like similar when you do like scraping with like soft tissue work.
I was triggered from that. That one. Pithing maybe.
Yeah, so anyways, the idea is that you are poking or kind of getting into the muscle to wear down or like fatigue the stronger parts so that you limit the stress shielding, so that when you do your exercise, you're getting more efficient results because the weaker parts are having to work more. I mean, we've talked about this before, how many times, about scraping and soft tissue work, and this idea that, we can use a device on the skin, like a piece of metal, and anatomically influence the tissue that is below the skin, below the subcutaneous adipose tissue, through the fascia, and then down to the fibers of the muscle and the tendon. Not to mention, we are giving ourselves a lot of frickin' credit to be able to say we are specifically targeting the stronger parts of the tendon. How in the hell do we know that we are scraping the strong parts of the tendon and we're leaving the weak parts be? Even let alone saying that the scraping is doing any GD good through all those different layers of tissue. It just, that part to me, like this is actually one of the parts where I do have a little bit or a lot of bit of an issue promoting this type of thing, because it's like my God, dude, like we're still on this track of this idea that we have X-ray vision and that I use a metal tool and I'm identifying microscopic structures with this giant tool that I'm pressing over the entire body or the entire area of that tendon or muscle or whatever it is. It doesn't add up to me. And this is a hill that I will die on, probably. Hopefully. Because if it comes out later in research that everything that I've been bitching about for the last several podcasts is wrong, I'm going to look like an idiot. But I'll wear that. I don't care. Right now, I will die on this hill. It just doesn't make sense to me. This idea that we can isolate these different parts of a tendon with a metal tool. Yeah, I don't buy that. I wouldn't go with that. If you listen to the podcast, please don't go to your physical therapist and say, I listened to the Tim Ferriss Show podcast and they said that I should get scraped and so that I can get the stronger parts of my tendon so it's not stress shielding anymore so that my exercises are better. Please don't do that. Don't put your physical therapist in that position.
Well, they might like it if they do all tool work.
Well, okay, then that's a different story, right? If the patient's bought in, if the patient trusts the physical therapist, and we know that trust of your clinician can yield better rehab results, if that's the case, and then, okay, but that's a completely different reason as to why this is working versus what Dr. Baar presented.
Yeah, I think the scraping comment he made, that was not cool. At least that's our bias. I wouldn't even say it's just ours. It's like it's very prominent in our profession that scraping is not changing your tissues structurally. It does not do that. It just doesn't. But it can make you feel better. It's a form of massage, and if you like it and you want to do it 100%, please do it. I don't care. Just don't expect it to be magically healing the weaker parts of your tendon. Now, the pithing, that is a common surgical practice. It's very common in dry needling. Pithing is you just take a needle and you poke holes into the tissue that you want to poke holes in. And the idea behind it is that when you poke holes, you are causing damage. You're making the area bleed, and your body is then going to have this cascade of healing response, and that is supposed to jumpstart or just like reinvigorate the healing process. So a common example of that is going to be a microfracture surgery that surgeons do in a knee. If you have a cartilage defect and it's gone down to the bone and you have this exposed bone that's pretty painful, doctors can go in and they can stab it a bunch of times, and that causes bleeding, and it causes your body then to fill that hole with some different type of cartilage that hopefully works well enough, and it works okay. It's a decent surgery. And then more for physical therapy, physical therapists that are dry needlers, Eric, are really into the idea of poking holes in your tendon for the exact same reason, to make the tendon regenerate, because for some reason your body has stopped causing that part to adapt. And the problem with it, as far as I've read, is that in physical therapy practice and tendon rehab, it's not some like magic wonder drug. It might work a little bit. It doesn't work for everyone. I think the rationale is like good on its face. It's just like, does it actually work that way in real life? In vitro versus in vivo? Unclear. But I think as we do more studies with dry needling and stabbing tendons and making them bleed, we're going to get a better idea of what needs to happen. But the thing that bothers me about that is my little mini rant, is that you get all these freaking physical therapists talking about, oh yeah, how many times do you poke the tendon? I poke it 20. Oh, I poke it 40. Oh, do you poke it like down, or do you go different angles, or do you twist it? I'm like, Jesus, can we just like not talk about all these different numbers of poking and just follow some research that we have here? Anyways, that's a minor thing.
Yeah, and what I'll say to that, as someone who uses dry needling part of their practice pretty regularly, I tell my patients, I tell them all the time, I say, I don't want to put anything into your body. Like, I don't want to have to dry needle you. It works. I like doing it. I think it's a great tool to have. But, like, I would rather we do other things, like if it's isometrics or education, or maybe, hear me out, soft tissue massage, but more so for the peripheral and central nervous system benefits because of analgesia, not for the reasons that are put forth in this podcast. That's why I would do that, versus someone coming in and looking at them like, oh my God, I need to poke holes into your muscles and tendons. Like, this has to happen so that we can get better results. No, it doesn't have to happen, but it's a tool to have if things aren't working. This is what irks me, because I know for a fact I've had it happen firsthand. I've worked with these people before, and it just pisses me off. But now, when you talk about scraping, personally, I don't think that's like it's not a skill that takes a whole lot of effort to learn how to do. Anybody can do it. Zero skill. And so, anybody can pick up a piece of a Graston tool and just start rubbing it into your skin. I almost let one go there. And make you hurt and tell you all this cool crap you heard on a podcast about why it's making you better. And they don't even know the research behind it. All they know the research from is because some guy said it on a podcast. They start advertising it like it's no tomorrow. And then everyone's starting to come in and they start propagating this message that isn't true to the best of our knowledge of what we know. Unfortunately, these people are not usually people of the rehab profession. They're of a different profession that can be associated in this type of industry. And I won't say specifically, but we start crossing these lines of what is fitness, strength, performance, etc., and what is rehab, right? What is recovery? What are these different things that we're doing? 3, 4, 5 too many times have I had individuals who aren't rehab professionals think they know what they're doing with certain athletes, and they're actually harming them rather than doing anything good for them because they think that something like scraping is going to benefit them, or something like early loading or heavy weight bearing on a structure that is inherently injured and should not be loaded in this type of way. And it actually puts the athlete back, and it actually hurts the athlete more. And then it's people like you and I, when the athlete isn't doing well, we have to step in and try and right this whole wrong because people think that they know what they're doing because they heard it on a podcast. Anyways, that's my rant. If we want to cut that part out, we can cut that part out. That's why I got so fired up when he started talking about this whole idea of like pithing and scraping and you know, causing the stronger parts to be not stress shielding and all this other stuff. I get the argument at its face value, but we just don't see that in clinical practice.
Yeah, and our job as physical therapists, as healthcare providers, is to really only provide you things that we know work.
Yes.
Maybe they're going to work to different degrees for different people based on whatever circumstances, but by and large, they work, and we have pretty good evidence that they do so. And if you're looking for alternatives to the stuff that we might practice, or physicians, or your chiro, there are other therapies that are out there that are being studied because we always are trying to grow our game as healthcare professionals, but they're just not there yet. Like we don't have enough research on them that's sound, or they have a really good in vitro background where they seem to work on petri dish things, but they don't actually work in real people, or we just don't have the parameters of them dialed in yet. And examples of these things are going to be scraping is one of those where the rationale for it that's perpetuated is just false, but it does help people feel better, but it's more of the massage aspect than it is changing your tendon structure. But another big one that's out there these days is red light therapy or other kind of laser therapies. Those things have evidence. You can go to Google Scholar and look up studies, and they're going to be there, but they're not in robust like people studies. And then you have other things that are showing more promise that are definitely entering clinical practice, but we need to know more about them. And that's shockwave therapy. That one seems to actually do something meaningful to tendons in particular, where it's mostly studied. But it's also like how often do we do it? For how long? What are the parameters? What kind of tendons does it work for? What kinds of people does it work for the best? Those things we don't fully know yet. And then another big one that's really popular, or at least more commonly known, is PRP, or platelet-rich plasma. That is one of those things that I am just still on the fence about. I know a lot of doctors will do it. They recommend it because it's kind of like a last-ditch effort if you failed all these other things that we provide you. But when you look at the studies on PRP injections for all over the body, the general consensus is that they're maybe effective, probably not harmful, but it's pretty much a coin toss whether it's going to be helpful for you. People, at least in our area, it's not covered by insurances. So PRP is one of those things that is paid out of pocket, and it can be very expensive.
Yep.
I think one injection at the place I work is like $700. I think it might have just gone up, and if not more in other places. And I know that people get pissed off when they're like, wow, my insurance isn't going to cover this treatment. What the hell is going on? Like, I need this thing. I need this help. It's like the one thing that the American healthcare institution does decently well is because it is for profit. The insurance companies do want to do things that have decent evidence and are probably going to work and are a good investment for them. I'm not defending them really in any way. I just think that that's one decent thing that comes out of it. And PRP just doesn't have the scientific rigor yet to say that it is definitely going to help you. Like, we can quantify it in this way. And so you lump all those things together, the red light therapy, the shockwave, the PRP, the other kinds of injections folks are doing. And that's where you get a company like QC Kinetics, where they make you pay thousands, tens of thousands of dollars to do all these different things. And maybe, I don't know the exact numbers, but like maybe 1 in 20 people get some kind of benefit, but it's not actually doing anything. It's just, you probably got better over time on your own without those things.
Probably just natural history.
Yeah, honestly, probably. A lot of other things to think about there, but like, I've had so many people, because QC Kinetics is actually across the street from where I work.
Nice.
Yeah, it's pretty
Nice.
They did a really good job with their positioning there. But I'll get patients that come from there, and they're like, I spent $10,000 of my own money over months, and I got nowhere. And then I'll work with them, and they're getting better in like 3 months, or if not less. I'm like, I'm so sorry. Like, but like, when you're in pain, you're just trying to get help, and I get that. I'm definitely sympathetic to that.
Yeah, 100%. To go off your point, I read a research article on PEMF not too long ago, and it was kind of like a review article of all the different literature out there. It was not quite like a systematic review or anything, but it was just some guy talking about, here's the literature, here's what it shows. And I'm probably going to butcher what PEMF stands for, because pulsed electromagnetic field. Okay, that's what I thought it was, but I didn't want to sound like a dumbass. So, pulsed electromagnetic field, the idea is that it's sending electrons through the cells to vitalize them and kind of optimize the cell health. So I'm like, I saw this online, and I'm like, what does the research say? Because again, a lot of in vitro studies, but not a lot of clinical practice stuff. And literally, I'm just paraphrasing the study, but it said that there's such a mix of studies that show little to no help or help, and who knows how strong these studies are. And it literally said, we don't know what the research says to be what the research is clear about, and there's not enough large clinical trials on this, so we can't actually recommend if PEMF is a beneficial thing to do. And that's where we get into a lot of these different strategies, is just the research behind it. Yeah, it sounds cool. It looks good in these smaller studies. The theory behind it sounds really cool, but we just don't know for sure or not. And I'll tell my patients, I tell them, if you think it's worth your time and money, and I think you probably do the same thing as well, Christian, but if you think it's worth your time and money to go get it done, and you think it helps you, and then go get it done. Go do it. I'm not going to sit here and say don't do it, but it's our job to try and tell you what is going to be best for you, for your time and your money, and not try and swindle you out of hard-earned cash that you have. So I think that there's some of these things that you have to really get into the weeds on, because when you say it's researched and you use some fancy words, it sounds great. Sounds like it should work. But when you break it down, what really works a lot of the times, kind of going back to this podcast, exercise, education, natural history, maybe a little bit of manual therapy. That seems to be kind of the bread and butter. And I'll just end my thought on this. In physical therapy, several decades ago, we were doing things that didn't have a whole lot of large clinical trials on. You look at things like ultrasound. That was something that everyone was doing. Back in the 90s, early 2000s, everyone had 3 or 4 ultrasound machines, and we were ultrasounding the crap out of areas. Shouldn't say they were. We weren't practicing yet. But that was a very popular thing. And then as more research came out, and we realized people aren't really getting better using ultrasound. It sounded cool, it looked cool, it sounded like it should work, but when you put it into large clinical trials, people weren't really getting that much better versus putting it up against something like a sham process. And so it's not that to say that physical therapy, that we've been blemish free from all these different things. Like, we've tried those different things, but I just think what's setting physical therapy apart is we're coming to our senses and saying things like, all right, some of these different modalities, we got to let this go a little bit. And what is actually working? Education, exercise, natural history, modifications, etc. That's what really seems to be getting people better. And to give Dr. Baar a lot of credit here, the work that he did in isometric research, I think it has a lot of promise. I give patients isometrics. I know that you do as well, Christian. It works. And but it fits into that bucket of exercise, things that we're already doing. Should we be doing more isometrics? Should we be implementing this more into our practice, especially within something like tendon or ligament rehab? Maybe, but it'd be nice to see larger clinical trials done on it. But anyways, I just want to end my thought on all that with saying that PT, we're not blemish free, but what Dr. Baar presented in this podcast overall, when talking about things like isometrics, 100% agree with. And I hope that it continues to gain more traction, because there's a lot of things in physical therapy that we just don't know with 100% certainty is going to be your bread and butter. But if something like isometrics comes along and it really looks like this is how we need to do it, and then hell yeah, that would be awesome. I'm really pulling for that. But overall, loved the podcast on the isometrics. That part of it, loved it. I think it's great. And I think I'll probably start using more isometrics because it looks like, it should help. And there's a lot of place for that in rehab.
Yeah, I just want to bring this thing home on isometrics and eccentrics, and then give some guidelines on loading for isometrics. So you did a good job wrapping up our general thoughts on isometric. And then just to remind people, eccentric loading has been the standard of care in physical therapy for a long time. Like, yes, we all do isometrics, eccentrics, and isotonics, but generally any recommendation you see is going to be do eccentrics at some point in the rehab process, because they tend to work the best in the studies that we have, which are done on real people and lots of them. But I do see a lot more potential for isometrics, and I'm going to look more into this. And actually already have been putting it more into practice just because why not?
Yeah.
But it's possible that different loading types, so isometric versus eccentric, drive slightly different adaptations. Isometrics might be particularly good for increasing tendon stiffness and directly stimulating cells in a very targeted way. Those cells in the hole, not so much the donut. Eccentrics are probably going to be better more for that dynamic load, getting someone closer to that return to sport, because you have to get those muscles working through their whole range of motion under decelerating type loads, because that is what happens in sport. And the question might be less about isometrics over eccentrics or vice versa, and more about when, why, and how to best incorporate each based on the desired effect and the stage of rehab that they're in. And so going into some general recommendations for these isometrics, hold time. It really can be anything, but like 10 up to 60 seconds seems to be what people do in the research. I'm more of a 10 to 30 second kind of person, just because 60 seconds is an awful long time to make someone sit in an isometric. And it seems to work better with shorter ones that are done heavier, at least for patient buy-in. Now for the load, this one, Dr. Baar did a good job of explaining in that you want to add enough load to where you feel some kind of stress or strain or tension happening in that tendon or in that muscle. And it's okay if you get a little bit of discomfort or pain. We often say to our patients, I want you to get up to 2 or 3 out of 10 pain, but no more than that. And that seems to be a pretty universally accepted amount of pain to get someone into and still get a really, really good effect without risk of injury. If you're more of a numbers person, that's going to be like, ideally, the load is going to be upwards of a 7 to 8 RPE or a 70 to 80% of your maximum voluntary contraction. Now, for sets and reps, this is kind of like hold times. There's a ton of different ways to take it, but generally, you might do 3 to 5 holds per set with 1 to 3 sets per exercise. Or, as Dr. Baar put it, you're trying to get about 5 to 10 minutes of total holding time in a workout, and then you're going to go through that refractory period, at least to use his framework here. That's 6 to 8 hours of just resting then, and you can do it again later. And now rest between holds, really just go when you feel ready, but that's 15 to 60 seconds. And then between sets, standard rest between sets is going to be 1 to 3 minutes like any other exercise. And then how often can you do these? Well, 1 to 3 times per day if you follow Dr. Baar's recommendations with the refractory period. But really, any number of times a week, that's up to you and your clinician to help you figure out. But generally, I try to aim for a 1 time a day or day plan early on, then I eventually shift to every other day, then eventually 2 to 3 times per week for different exercises based on the client's goals and their preferences.
Yeah, I thought you put that really well. I would agree with what you laid out there. And I think the how in terms of the exercise, like, well, what exercise do I choose, right? I would argue that if you're in a more irritable state, you should keep it pretty simple. If you have some pretty nasty anterior knee pain, I would just stick to knee extension isometrics, right? Either on a knee extension machine or up against a wall or into a Bosu ball, or not a Bosu ball, but like an exercise ball into a wall. I would just start out single joint, keep it easy, a very well-controlled environment. If you're pretty far along on this and you have pretty low irritability, or if this is a new thing and it's a low irritability, but you don't want it to go progress anywhere. And then, I think that Dr. Baar put out like holding like a lunge or a split squat position, because he talks about, well, now you're getting more than just the knee. You're going to be getting more to the ankle as well, like the Achilles tendon. And it's just a more demanding movement, right? And so I would say if you're low irritability or it's a new thing, you could give a try with a more complex position like a lunge hold. Or if this is a long-standing issue and it's really irritable, I would start more simple single joint type movement like a knee extension. Just the last thing that I want to talk about to get your take on it, Dr. Baar on the podcast discussed how if you go to, like an NFL gym, right? The guys that have been doing it for a while and they know what they're doing, they're going to be doing machine work. Machines load the tissue most in their strongest position, load them the least in their weaker position. That's going to allow for, better adaptation and less stress on the body, etc. And, he was talking about how, like, the rookies, they don't know what they're doing. They're out doing barbell, kettlebell work, explosive movements, etc. And how that's providing a lot of jerk and causing a lot of stress to the body. I don't think he said this, but it sounded like he was insinuating like it could leave him more prone to be injured. I feel like I have a mixed bag of emotions on this one, because he was discussing how less jerk during your workouts, less chance of being injured. But I feel like if we're just doing machine work and it's in a controlled environment, we are taking away this idea of specificity completely out of the picture. If you're an offensive lineman, how often are you sitting in a chair pushing like this when you're playing your sport? Never. You're standing. It's a very dynamic environment. There's a lot of stuff going on around you, let alone taking the legs out of the equation. I feel like there would be a middle ground somewhere. I get what he's saying about how machines are going to offer less harmful stress and load that's possible to the tendons and whatnot when you're doing more dynamic barbell, kettlebell, free weight type movements. But that offers us the ability to be a little bit more specific in the training that we're doing versus only doing machine work all the time. I'd be curious to get your take on that, Christian. I feel like there's a middle ground somewhere.
I don't work with NFL athletes. I don't ever claim to be an elite athlete, coach, or physical therapist, at least of that caliber. But yeah, there's lots of thoughts there. Once again, I think he's just being edgy when he says that. There are so many reasons why that might be the case, if that even is true, but let's just assume that what he's saying is true. Well, one, those older athletes have probably already done all that work over many years, and now they're just maintaining. They don't need to work as hard to keep building because they're already built. They're just trying to stay where they're at.
Yeah.
Because maybe they've recognized that where they're at is enough to make them succeed and be really good at their position. Also, older athletes carry their battle scars. They've been hurt a lot more than younger athletes, probably. Right. And so maybe they're choosing exercises that still provide a lot of stimulus, make them feel good, and there's just less issues with all the other injuries that they have, all the other baggage that they're carrying right now. And then maybe because they're older athletes and they're all humans, they don't have much to prove anymore. They've already proved it. They're veterans. And maybe older athletes don't want to try as hard as a new 22-year-old recruit. Like, I don't know. There's
Yeah.
just so many things to unpack. But generally, I would assume that if the athletes had the motivation and they weren't restricted by injuries and they had the time and all that, they would probably be doing the harder barbell lifts with some machines, of course, because why not? They're great too. But because of what you said, because there's more sport specificity, you're getting your body to move through more range of motion, which we know to be injury preventing. When you only train certain ranges of motion or partial range of motion, you're only good at that range. That's and like maybe a tiny bit of carryover beyond that, but that's something we've known for a long time, and something that's just like standard of practice in strength and conditioning and rehabilitation is you get people training with more weight through more range of motion and you add more variety. If you do those three things really, really well, people perform better and they have fewer injuries. And so I don't really understand why Dr. Baar would say you see these athletes training with machines through their strong range of motion and not working on their smaller muscles. He said something kind of like that too. And so
Mm-hmm.
that doesn't make any sense to me. I don't buy that. And if they were, I would say probably need to be changing something about their plan. But I'm
Yeah.
also a pro athlete, so like, what can I say?
Yeah. It's okay to take a stance.
Yeah, right.
But yeah, no. So, anyways, I would say quick recap here. Isometrics show promise. They show like there's some good stuff in store for them. We already prescribe isometrics for reasons that were said today. I think that the stuff that Dr. Baar is doing is fantastic. That's the frontline work that needs to be done in order for things like this to propagate into clinical trials, etc. And so I thought the podcast overall was really fun and great to listen to. And, obviously there's going to be points where we're going to discuss and might have a little bit of contradiction to it. And that's totally fine. But in general, yes, I agree with what he's talking about the isometrics. I thought he laid out a lot of stuff very well and how he gave a lot of good background to different things like stress shielding and jerk and the different loading parameters and the research behind that stuff. Yeah, I thought it was good. And like we said, I think I'll probably start using a little bit more in my practice and kind of see where that goes. Because when it's something like isometrics, you're not putting the patient at more harm, right? You can kind of play around with that stuff a little bit and see what works for the patient.
Yeah, great summary.
But thanks everyone for listening. We appreciate it. And we'll be back next time with something else. We'll wait and see. So, all right, Christian, thanks so much, man. Appreciate it.
See you, Eric.